Okay, 8 o'clock, let's get started. Good morning.
Good morning.
Day 2, welcome back. We didn't lose anybody, did we? Good. Just let me mention before we start, we got a couple emails yesterday regarding the when the video was uploaded, and it took about less than 2 hours yesterday. It's automatic, and we don't really have control over it. Once we stop recording the class, then it's all right. And once we start recording the class, then the machine does whatever it does, and I said it usually takes an hour to be online. Yesterday it took 2, so I apologize. So we'll track it and see how long the average takes. I bought a new machine, so maybe it's a little slower, I don't know. We'll let you know. But anyways, it is online. It was up by about noon, so stay tuned. If anybody has any questions about anything that I forgot or did say or said yesterday, please let me know. What I'd like to do is just backtrack for a minute to where we were yesterday, and I'm going to start on page 7. So let's turn to page 7 in the book. Okay, so we started out by giving you some idea of the different subfields of pharmacology. I won't go through them again, they're pretty straightforward. But the areas that we're going to cover in fairly large detail. And then the bottom figure shows a lot of other areas as well, all touched by the drug world. And then started out with my 4 areas on page 12, introductory areas, and I said that's what we're going to do through the next 2 classes next week as well, and then we're going to start the anesthetics. So the first area is receptor theory or pharmacodynamics, and I started by saying that drugs, of course, work on receptors in the body everywhere a drug goes, unless it's strictly a substitute. You're substituting, you had your thyroid taken out and now you take thyroid hormone as a substitute. That's not really working on a receptor, it's just substituting the substance. But 99% of drugs have a specific receptor in the body where they produce their action. And drugs, when they bind to the receptors, are either agonists, they stimulate the receptor to do what its function is, are antagonists, meaning they attach to the receptor. They both have affinity, they both attach to the receptor, but one sits there and does nothing but blocks anything else from getting there, and an agonist stimulates it. You can have, on page 12, you can have competitive or non-competitive binding. Competitive means the drug will wear off eventually when something competes with it, or non-competitive means it's a permanent action of that drug. And then I jumped up to page 16, said the different ways that drugs can bind to receptors with varying strengths of binding, starting at the top with the strongest, were covalent bonds, then followed by ionic, hydrogen, hydrophobic attractions, and van der Waals forces. And then finally we ended up on page 18, talk about dose response curves. So that's why I kind of want to pick up where I left off before. And that was, you can, once you figure out a drug may be beneficial to treat a particular disease, then you obviously have to quantify its action. How many milligrams or grams or micrograms or whatever, how much a drug, what's the dose is going to take to produce what effect, what are the side effects, yada yada. So you got to do all that. The FDA requires certain studies in animals and so on, And one of the first things you always do when you characterize a drug, and you'll see these throughout this whole 2 semesters, we talk about various drugs. There'll be dose response curves for this or that effect. And so let's take a look at what they are. And what they are is, if you follow my little cursor on the screen, you plot the dose versus the effect. The dose on the x-axis here is done on a log scale. There's other ways you can do it. You can use double reciprocal scales or straight lines or whatever. The most common way is to do a log dose and percent effect. From 0 to 100% on the y-axis, and then the increasing doses. And if you do that, the curve comes out like an S, like this, called sigmoidal curve. And you get, then you can tell 4 things by figuring this stuff out. So you give it to animals, a population of animals like 100 or 50 or whatever. You measure how many milligrams produce what effect. You plot it all out like this, and then you can know, and if in the bottom of page 18, you can know the potency of the drug, or affinity for the receptor, the efficacy of the drug, that is, can it produce the effect that you want at 100%. Note that there's some variability, and we'll just take that for granted. And then note the slope of the curve, and that's an indication of toxicity, which you'll see at a later time. So I think that's kind of where we left off yesterday, and so I kind of want to pick it up from there and continue on. So let's go on the next page, page 19. Now here's 3 drugs. I've labeled them drug A, B, and C. This is from Miller's textbook, Anesthesia. And so he's comparing the dose, these 3 drugs, plots out dose response curves, and he comes up with curves that look like this. All right, so what do you know about these 3 drugs? First of all, which one's the most potent? A. Next potent? B. All right, that's pretty simple. And the least potent is C, right? Which one has the highest affinity for the receptor?
A.
Thank you. Next?
B.
Next?
C.
Okay. Which has the highest efficacy?
Well, they're all.
They're all the same, right? They all have 100%. In other words, if this is 3 drugs that produce, antihypertensive effect, they'll all produce the drop in blood pressure the same. It's just going to take a different dose to get there. The efficacy is the same. See, they all reach 100%, right? And they have a certain variability. Yeah, we assume that. So what? Who cares? And then we can look at the slopes. We'll do that at another time. So let's see what Dr. Miller says. I should have a legend in the bottom here. The dose or concentration versus response relationship. A sigmoidal curve is generated when the log dose is plotted against the percent effect. The response curve is shifted to the right in the presence of an antagonist after we'll talk about that a little bit later. So anyways, this is comparing 3 drugs. You can see which is which, right? Now, let's take a look at page 21. Same thing. Here's 3 drugs, comparing them, and forgot. Right there. And they're looking at the therapeutic, toxic, and lethal effects. And you see this sigmoidal curves, probabilities, and they can plot out each one. So let me show you what that is. This is where I'm trying to get. There's a point to all this, trust me. And this is, so look on page 22. So here it is. You do these dose response curves, and you can determine some dosing issues with the drug. First of all, if you look at the effective dose in 50% of the rats or mice or people or whatever you gave the drug to here, so let's say that I got up to 100 milligrams And I was at the 50% efficacy point. Extrapolate that over, see that's 50%. Everybody see how I'm doing that? All right, we call that the ED50 of the drug. ED means effective dose. ED50. Every drug has an ED50. The effective dose in 50% of the people you give it to. Or you could say effective dose to get you 50% to the efficacy. They both work. Now, we always talk about the halfway point. It's just an agreed upon thing. Clinically, as nurses, when you go in and take care of a patient, do you want to give them the ED50 of the drug? No, because half the people won't have the effect you want, right? What do we give? We give the ED99. We never commit to 100%, right? At a fair commitment. In pharmacology, they only go ED99. So if you look up in a package insert, the usual dose in an adult 70 kilo male or female is 10 milligrams. That's the ED99 of the drug. And that's what you use clinically. But in pharmacology, we always go 50%. So that's ED50, okay? So then let's say you do a whole other curve, varying doses against some response. In this second experiment, what the response you're looking for is something toxic. Let's say you find out this drug produces a rash, or this drug makes your hair fall out, or this drug makes you throw up, or whatever. I mean, something bad, right? Causes severe hypotension, some toxic effect, right? So you do a dose response curve and figure out what dose required to produce that nasty effect, the toxic effect. And they're showing you here, if you do that, you got up to about here, let's say that's 200, and I'm just eyeballing it, 250 milligrams, we'll say. And you got 50% of these mice to throw up, whatever the toxic effect was. All right, we would call that the TD50, the toxic dose in 50% of the population. TD50. And then finally, you do lethality studies. You give a dose that will kill the animal, and you figure out what that dose, you get 50% of the little mice to die. And they call that the LD50, lethal dose. So you always want to know the ED50, the TD50, and the LD50. You'd like these doses to be as far apart as possible, right? Sometimes they aren't. Now, if you then divide the LD50, I'm showing you right here, the LD50 over the ED50, then that gives you something called the therapeutic index. So the therapeutic index of a drug is a safety measure of the drug. It tells you how much you have to give to kill something versus how much the effective dose is. The higher the number, the better, right? So let's look at this. The LD50 of this drug is 400 milligrams. They're saying it right here. See, LD50 is 400. The ED50 was 100. So the therapeutic index is 400 divided by 100. Follow my little cursor here, or 4. So the therapeutic index of this drug is 4. It takes 4 times as much to kill you as it does to cure you. Lethality versus effective. Okay, does everybody see that? Let's go back a page. That's what they're trying to show here. Same thing. They're doing how much is the therapeutic effect. They do a second experience with the toxic effect, TD50. Third experience with the lethal effect, LD50. And they can determine all 3. Therapeutic effect, toxic effect, lethal effect. Now, if you go way back when, sorry, I wrote it out for you. On page 12, let's go to page 12. They have you switching around pages that keeps you awake. So on the bottom of page 12, I wrote this all out for you. You'll see ED50 is the effective dose in 50% of the population. The TD50 is the toxic dose in 50% of the population. The LD50 is the lethal dose. The LD50 divided by the ED50 is called the therapeutic index. Now there's also something called the therapeutic window. And I got the definition here. The therapeutic window, or some people call it pharmacologic window, mostly therapeutic, is an index for estimation of the drug dose, which can treat the disease effectively while staying within the safety range. It usually looks at the TD50 versus the ED50. Now, as a clinician, as a nurse taking care of a real patient, it's much more important to know the toxic effect versus the effective dose versus toxic dose. We don't expect to go in and give a drug and kill people, right? It's not the normal thing we do. So, but we are looking for toxicity. We are looking for, causing the patient's breathing problems or rash or, whatever, nausea, vomiting, so on and so forth. So that's usually something that's a little bit more useful clinically. And so let's take a look at page 24, and I plotted it out for you. All right, there's the a plot right here. I'll go on to this blue line. There's the ED50, and here's the TD50. All right, the therapeutic window is going to be, you want to know how much is going to get me to 100% efficacy, because you want the patients to be cured, right, or get the effect you want, versus how much it's going to be down here, you're going to start to see toxicity. So the therapeutic window is this little light blue part. It's the point where you can get effect without getting much toxicity. You see there's a little overlap. Most drugs there is. Very rarely you're going to be able to give as much as you want without getting some sort of side effect. Something. That's therapeutic window. The therapeutic index is the ED50 or the LD50. And they're showing that here. See? Let's go to the next page. Same thing. I did the same thing over. I like to repeat myself. The therapeutic window is a range of doses or plasma concentrations that produce therapeutic response without any significant side effects. In general, the therapeutic window is a ratio between the ED50, the effective dose, versus the toxic dose. So they're saying here, see, here's the therapeutic window, the yellow part. Now, the therapeutic index is ED50 divided by LD50. They're saying toxicity, yeah, lethal, that's toxic. So, anyways, that's the difference between the two. We usually run around here in the therapeutic window. We want to get the patient cured without causing toxicity. We're not going to spend time up there where the lethal dose is. Right? At least try not to. So another way to look at it, here's the therapeutic window. This is page 26. Here's the toxic concentration, TD50s. ED50s in the bottom. So there's a window, a range between the two, and you try to give dosing, and the patient takes a pill, peak and trough, another pill, another pill. You try to ride around in that therapeutic window. See what I mean? Basically, I'm not worried about being able to figure all this out. I'm worried about the language, the definitions. So when you walk out of class today, I want you to say, if somebody says to you, what's ED50, TD50, LD50, competitive, non-competitive, agonist, antagonist, ligand, therapeutic index, therapeutic window, look at all the stuff we learned already. I just met you. You're just a font of pharmacologic knowledge. So anyways, I just want you to kind of get the terms so we can start using some of these, and then we'll worry about figuring it out. Remember, this is only the second class. We got till next year. We're going to get this all done, all right? But I want you to have some feel for the different terms that people use. All right, go to page 23. Okay, this is real drugs. So what they're saying is, they have patients. Let's read the label, the legend. This is a series of dose response curves for a population of patients receiving pain meds. It's a log dose scale on the x-axis and percent effect on the y. So here it is. They gave morphine. Here's, first of all, here's morphine. And you got up to 100% efficacy. How much did it take? Oh, I'd say a little less than 20 milligrams, right? I'm just eyeballing it. What's ED50? 7 or 8 milligrams, maybe. Right where my cursor is. All right, here's Demerol. Same thing. They both have 100% efficacy. I can get the same amount of pain relief from morphine as I can get from Demerol, or vice versa, I guess. It just takes more milligrams, right? It's showing that here. So ED50 of Demerol, meperidine, is going to be higher than the ED50 of morphine. And we know that. Demerol is about 10 times less potent, so 10 milligrams of morphine is about the same as 100 milligrams of Demerol. Right? Does it matter clinically? No. Because the company's going to make it, the strength that you need to inject is 1 cc of morphine is 10 milligrams and 1 cc of Demerol is 100 milligrams. They're going to figure that all out before they even bring it in the hospital. So it's not going to matter. So morphine is about the 10th of potency, but potency is not a big point unless it's so extreme that you can't even make a pill big enough to swallow or something. Right? So there's morphine, there's Demerol. Now this is drug X. It's showing this one. But what about drug X? Do you know? It doesn't have the same efficacy, right? Number one, and you're right, it doesn't have the same potency as morphine. It's more potent than Demerol for a little bit of ways, but you can't get 100% effect. You can't. It looks like you can only get about 50%. There are a class of narcotics called agonist, antagonist, toluene, nalbuphine, butorphanol, Stadol. You'll run into them at the end of the semester. We use them in anesthesia sometimes. And they're kind of, lousy narcotics, but they don't cause much respiratory depression. That's a good thing. Now this last one, this is Demerol plus Narcan, naloxone. Right, this is an experiment. This isn't a real person. Right? So they go into animals and they give them all 0.4 milligrams of Narcan, a cc of Narcan. Then they try to give them analgesia. And what do you see? After giving morphine after you've given the mouse Narcan. Well, you can still get to 100% efficacy. It's just going to take more because you gave Narcan first. Duh. Right? This is an experiment. These are animals. They're trying to prove a point. But what does this tell you? Well, first of all, the effect's competitive. You can compete with the Narcan for the receptor. They both want to get an opiate receptor. Narcan's going to be on there. You can start giving morphine, and you start giving Demerol. And you want the Demerol on the receptor so you get analgesia. You'll get the Demerol on the receptor. You just have to give more of it. So there's more Demerol in the synapse than than Narcan. And it's going to take more Demerol than it would have if you didn't give Narcan first. The dose response curve here is shifted to the right. See that? All right. If this doesn't make sense, go ahead. It's fine. You can tell me. I'll be glad to say it over again. But what it means is, if you have an antagonist first, you can compete with it. It's competitive antagonism. It's not permanent. But you're just going to have to give more Demerol to do that. You got to 100% efficacy, see? They all were the same. Make sense? Let's look at page 27. Look at page 27. Here they're doing theoretical, these are experimental things, computer simulations. And they're looking at how much anesthetic it takes. This is in standard pressure units, so it's a gas anesthetic, partial pressure, increasing amounts, versus the proportion of patients that don't respond. Of course, that's what we do for a living. We make people not respond, knock them out, right? So how many people didn't have any response versus how much anesthetic you had to give? Dose response. And what does this tell you? Look at it. What's the easiest thing to block in somebody's brain? If you're looking at this. Memory, right. Amnesia. It takes less anesthetic to make you not remember than anything else. It's the easiest thing to knock out. I have a good friend that says if you go to anesthesia, you don't go in and do it for the glory. Because if you do your job right, first of all, wear a mask all day and people can't see who you are anyways. Secondly, if you do your job right, the patient isn't going to remember you the next day. So you're not in there for the glory. We just sell it for money instead. I didn't say that. Oh my God, I'm being recorded. It's the personal satisfaction, that's it. Okay, so the easiest thing to do then, the lowest dose of anesthetic requires that you, for amnesia, for memory, right? What's the next easiest thing to knock out? Well, it's consciousness, awareness, right? That's what anesthesia, the definition of anesthesia is, loss of consciousness. So you can make them unconscious. Then it takes a higher dose to make sure you don't move in response to pain. Surgeon cut your belly open and you move. Even though you're asleep, you don't do it on purpose. You've had patients in comas that respond to pain, right? You pinch them or you do something nasty to them and they flinch away or reflexively move away from it. So you don't have to be awake to respond to pain. And then finally, look at the last one. Autonomic reactions. Just change in blood pressure, change in heart rate, sweating, breathing changes, release of hormones, blood sugar, stress steroid levels in the body. All those thousands of things the autonomic nervous system does that we'll learn about. And that's what we want to block all that. That's how the patient's successful. They don't have, the surgeon doesn't cut them and their heart rate ends up 160 because they're in pain. Even though they're asleep, they were asleep a long time ago. Everybody we do is asleep if we want them to be. Okay. So this kind of gives you an idea, looking at them, which one's the easiest to produce, which one's less, and we're going to spend a whole year talking about that, as a matter of fact. So hopefully that makes sense. Okay, so to sum it up then, drugs work on receptors. Receptors are there to produce a physiologic effect. And there's many terms that are used, or lingo. Again, that's agonist or antagonist. Both are ligands for the receptor. We have ED50, TD50, LD50, therapeutic window, therapeutic index. Let's go to page 28. All right, there's a couple other terms I want to get before we move on. On the top there, I wrote this little thing out. In pharmacology, we try to make things easy. It's called up and down, so it's not hard to remember. But what happens is this. Well, let's read what I wrote. Receptors not only initiate regulation of physiological or biochemical effects, but they themselves are subject to regulation. The synthesis and degradation of the receptors is controlled by multiple mechanisms. Remember, they're proteins and they turn over. You can turn over faster or less, you can have more, you can have less, whatever, you adapt. So, let's say, and look at here's my examples. Second paragraph, page 28. If you continually stimulate a cell with an agonist, that results in a receptor producing in pharmacology what we call desensitization. It becomes less sensitive to that agonist. So let me be really silly here and say it, but it'll make sense when I say it. All right, the receptor says to itself, I'm always being stimulated. That's not normal. I'm not supposed to have this much stimulation. So I'll become less sensitive to whatever's stimulating me. It's just so I can get back to normal. Your body always tries to get back to homeostasis, to a normal state. And it's perceiving this constant drug in there, stimulating the receptor, as being abnormal. So it tries to desensitize. And so there's two things that happen, both a quantitative and a qualitative change. Quantitative means receptors decrease in number. The body makes less receptors. It gets rid of some of the receptors and doesn't replace them. That's the one way it fights against this constant stimulation. Secondly is a qualitative change. Each receptor itself becomes less stimulated by that agonist. It's desensitized. So it's both a qualitative and quantitative desensitization to the response to the chronic agonist. Does that make sense? We call that downregulation. The receptor's downregulated. So let's read what I wrote. Second paragraph, page 28. Continued stimulation of cells with an agonist generally results in a state of desensitization, also referred to as refractoriness or most commonly downregulation, such that the effect following exposure to the same drug is diminished. So here's an example. This will make it make sense. Let's say you got asthma. You take those puffers, albuterol, little metered inhaler, and you puff it, and by the end of the day, you've taken a lot of puffs, and it's not working as well anymore as it did when you first got up in the morning. The more puffs you take, the less effective it is. All right? Clinicians would call that tolerance. Patients developing tolerance to the drug. In pharmacology, we call it downregulation because the albuterol is stimulating beta receptors in the lungs. The beta receptors are perceiving that they're being overstimulated, and so they're decreasing their numbers and sensitivity to the albuterol. And it takes more puffs to get the same effect as the day goes on. So the less puffs you have to take, the better, because it's more effective. If you can do that. All right? Does that make sense? So let's read what I said. Phenomenon is very important in therapeutic situations. For example, repeated use of a beta agonist such as a bronchodilator like albuterol in asthmatics. Clinically, the patients experience tolerance. It requires increased doses to achieve the same effect. Okay? Now, the opposite happens when you give an antagonist. You get upregulation. So let's say I have congestive heart failure, and my cardiologist put me on carvedilol, beta blocker, Coreg. Everybody who has heart failure is put on that, right? That's a beta blocker, so it blocks beta receptors in the heart. So what the heart's going to say is, my beta receptors are all plugged up with something. They're not working right. I better make more of them. So get things back to normal. So there's upregulation. So what happens is, after a week or two, the cardiologist has to shift the dose up a little bit to compensate for the fact that it doesn't work as well after they've been on them for a week or two. They need adjusting. Let's read what I wrote. Chronic administration of an antagonist results in upregulation. The number and sensitivity of the receptors increase in response to chronic blockade. And clinically, the patient experiences the same thing, tolerance. But in this case, it's because of upregulation to an antagonist rather than downregulation to an agonist. Both produce tolerance. Does everybody see that? What if you abruptly stop taking that Coreg? Well, then you got all these extra beta receptors the body's made to upregulate to try to compensate for being on the drug. You take the drug away, and they have a rebound, tremendous rebound effect. Tachycardia, hypertension, it's ugly. You have to wean them off, let the receptors adjust and so on. Question?
How quickly do those receptors normalize?
Each receptor population is different. With the beta receptors, they start to up or down regulate within the first 24 hours after you're on the drug. They will stabilize usually 3 to 4 days. Histamine receptors can do it in a matter of hours. So it just depends. Different receptors are different. Opiate receptors, matter of hours. Okay, so that's up and down regulation. Then finally, lastly on the bottom of this, I just want to get some terminology having to do with drug interactions and so on. So we can use these terms. And these are simple. First of all, on the bottom of page 28, the drug interaction or an interaction is an alteration in the therapeutic action of a drug by concurrent administration of another drug or food or some other chemical. All right, what's an additive effect of two drugs together? We say, oh, they have an additive effect, addition. Well, the simple way that pharmacology books say it is 1 plus 1 is 2. If you take two drugs together, if I give somebody Versed in the pre-op holding area, and to make them calm, then I take them back and give them propofol to put them to sleep, they're both sedatives, then what's going to be the difference, how they can interact? All right. Well, if there is an additive effect, it would be just adding up 1 plus 1 is 2. The amount of sedation you'd expect from how many milligrams of Versed you gave, will add it on to the amount of sedation you'd expect from how many milligrams of propofol you gave. Simple 1 plus 1 is 2. Does that make sense? Okay, synergistic effect. That's different. A synergistic effect is 1 plus 1 equals 3. So you give one drug that has a certain effect, you give a second drug with a similar effect, and you don't just add up the two. It actually, they enhance each other, so you get an even greater effect. You get a 1 plus 1 is 3 effect. That's called synergistic. It's a greater than expected effect from just adding up 1 plus 1. And in fact, Versed and propofol are synergistic. That's why we do it a lot. You get a lot less propofol if you give them Versed pre-op. Synergistic effect, 1 plus 1 is 3. Does that make sense? Okay, the next one is potentiation. This is probably the most commonly misused terminology or miscorrectly used. And this is the enhancement of action of one drug by a second drug that has no detectable action of its own. So it's 1 plus 0 equals 3, as I'm reading off my definition here. Right? So here's the example every pharmacology book in the world uses. You give somebody who's got an infection, you give them penicillin. And if you secondly administer the second drug called probenecid. And probenecid is a compound that just prevents acid drugs from being excreted in the kidneys. It just makes drugs stay in the body longer. You don't pee them out. Probenecid doesn't kill infections. It has nothing to do, it's not an antibiotic or anything. But if you give penicillin and probenecid together, because they potentiate each other, you get a better antibiotic effect. Because the probenecid prevents the penicillin from being peed out, it stays in the bloodstream longer and kills the bugs for a longer time, more efficiently. So there's an example of 1 plus 0 equals 3. You got one drug, an antibiotic, penicillin, added to another drug, probenecid, which is 0, antibiotic effect. However, when you give them together, you get an enhancement in 1 plus 0 equals 3. Does that make sense? We see it sometimes as a side effect in surgery. We give a lot of antibiotics during the case. Pre-op, inter-op, post-op, we're always giving antibiotics. A lot of infected people come to surgery, right? Or you prevent infections from happening, one or the other. And antibiotics can cause a drug interaction with some of our muscle relaxants and potentiate the muscle relaxant. So you go to reverse the patient at the end of the case and you can't reverse them. We'll learn all about it next semester. Right? There's a whole list of drugs, you're going to memorize them, or you're going to be an expert. But that's an example of potentiation. Antibiotics in and of themselves are not muscle relaxing, but when added to rocuronium or vecuronium or something, they can produce a greater muscle relaxant effect. All right. Then finally, the last one is an antagonistic effect. This one's easy. 1 plus 1 equals 0. This is Narcan reversing a narcotic. This is protamine reversing heparin. This is flumazenil reversing a benzodiazepine. So any kind of antidotal drug like that, a reversal type compound. This is Sugamidex reversing a muscle relaxant. Anytime you do that, it's 1 plus 1 equals 0. You got rid of the drug, right? Got 0 effect. Question?
So can you say that synergism increases potency and potentiation increases efficacy?
Potentiation increases efficacy, yes. It doesn't, synergism doesn't increase potency, but it increases the efficacy of the dose you gave. So I would say efficacy is true for both of them. Okay, any other questions? Good. Now, next page. Page 29. And the last terminology I want to get in this little part, intro part, is the term bioavailability. This is pretty simple, right? The bioavailability. It's something we deal with a lot in anesthesia. In pharmacology we do too. So the bioavailability of a drug, I wrote the definition for you. The percent of the drug contained in a drug product that enters the systemic circulation in an unchanged form after you give it, after administration. Okay, now, let me go off on a tangent here for just 30 seconds. Pharmacokinetics is the measurement field of pharmacology. It's the math of pharmacology. It's all the nerds, right, with all the calculators and the pocket protectors and all that. That's the kinetics folks. They put them on their own floor and they lock the door and they can figure that out. And in kinetics, they want to measure how much, kinetics is by agreement always the measurement of how much drug is in the bloodstream, right? We infer from that how much is at the receptor, and I'll show you that later in a later time. But we just by definition, to make it easy, because we can measure the blood level of anything, we just assume we talk about everything as how much is in the bloodstream. So you see most kinetics, 99% of kinetics figures and diagrams are always blood level over time. How long did it take for the blood level to get, and how long did it, so on. And we'll get into all that. I digress. But, so in kinetics, by definition, it's agreed upon that when you give a drug IV, there is no absorption. You automatically put it in the blood. And since we're trying to get it into the blood, that's the whole point. Since you start an IV, you've done this a million times to a million people. You start an IV and you squirt some drug in their IV, you're putting it right in the bloodstream, right? So that's where you start with. Do you have to worry about absorbing the drug into the blood? No, you just stuck it in there. You put an IV needle in and you put it right in the bloodstream. So look at my table here. The bioavailability when you give a drug IV is 100% by definition because you gave it IV and you put it right in the blood. That's what we're trying to define bioavailability is how much is in the blood. How much, look at my definition above. Excuse me. How much enters the systemic circulation? If you give it IV, it all enters it. You put it right in there. Let's take care of that problem. Let's just go to the next one. So there's no absorption. You just start with distribution, right? All right, how about IM? If you give somebody an IM injection, what's the bioavailability? Well, it could be anywhere from 75 to about 100%. How much is going to end up in the bloodstream is what they're saying. Usually less than 100%. Usually around 75%. Would be absorbed from the muscle and not be metabolized first and not go off somewhere else and then water or whatever. It would be absorbed. How about sub-Q? Similar. Oral. Could it be anywhere from 5, they're saying 5 to 100. I would say, I didn't write this table, I'd say anywhere from 0 to 100, right? Some drugs you just can't absorb in the stomach. Their bioavailability is 0. How would they test that? Well, they'd go in an animal and give it IV, and give the same dose orally, and see what the blood levels they end up with for both. If a drug has a bioavailability of 10%, only 10% of the drug is going to get into the bloodstream. You're going to have to give a high dose, right, to get enough of it in there. That's going to be a big pill. Or you're just not going to be able to give it orally. Our big example we use all the time in anesthesia is lidocaine. We use lidocaine for just about everything in anesthesia. We use it for spinals, we give it, grease our tubes with it, LMAs, we give it for regional anesthesia, we use it for arrhythmias, we use it to block cough during intubation, and on. I could stand here for half an hour and tell you all the things we do with lidocaine. You ever see somebody go home with a prescription for lidocaine? Never. Did they say anybody try to swallow lidocaine? Never. Why? Its bioavailability is 0. For reasons we're going to get into next. So you can give it IV, it works great. You've done it before, you all have. But if you try to swallow it, you got nada. Because you've got a 0 bioavailability. See what I'm saying? Rectal. If you give a drug in a rectal, suppository, so on, the absorption can be anywhere from 30 to a little bit less than 100. Inhalation. Inhalation drugs, that's very important to us. We're going to talk about the anesthetic gases. Can be anywhere from 5 up to 100. Transdermal can be 80 to 100, depends on the patch and where you put it, or the ointment, or the grease, or whatever you're putting on there. So there's just an idea of different routes of administration. I said yesterday, if you have a hole in your body, some drug person's going to try to figure out how to stick a drug through it and get it absorbed into the bloodstream. So these are some of the different ways that we administer drugs. And how much ends up in the bloodstream, that's what I'm trying to leave you with. The term is bioavailability. That's what percent of the dose you gave, whatever route it is going to end up in the blood. All right? Let's take a break. All right, let's start up again. And I want to turn to page 30. So the issues about drugs and receptors I'm going to leave alone for now. We're going to move on to something else, although I've got my terms out there and we're going to start to use them, and hopefully it'll make more sense as the days roll on. I made a bet a couple of years ago that I said if I ever have a class from now till April I don't say the word receptor, I'll buy you dinner. And a couple of years ago I actually did it sometime in February. The students at OHSU, the Oregon Health and Science, emailed me and said, "We got you. You owe me dinner." So I had a class where I didn't say the word receptor of the whole 2 semesters. So believe me, I'll be talking about receptors again. I never went back to Oregon, by the way. A whole bunch of people did that. It'll be meeting me at the airport or something. I don't know. Okay, I want to switch to introductory topic number 2, and that was pharmacokinetics. And so let's do that, and this will be a fun one. Introductory topic number 1 was, of course, drugs and receptors, and that's chapter 5 in my textbook. So chapter 5 is the issue about log dose response curves and efficacy and so on. So take a glance at chapter 5. And again, I want you to realize, I don't want you to read these chapters and try to memorize. I don't want you to read the chapters and get nervous. So what is he talking about? I don't know what the guy is, where the guy is. I just get the big picture. Look at the headlines and get the general sense of what's going on. This is, you've only been in anesthesia school for a couple of weeks. You're not expected to know everything. And this is not a beginner type of chapter. So read it. It's going to reiterate what I just went through. But again, don't worry about memorizing it. I'm going to tell you exactly what I want you to know. So it's going to be fun. It's going to be easy. Don't get nervous. Just take a look at chapter 5. It's relatively short. And that'll be for drug theory. Okay, topic number 2, pharmacokinetics. Now I said yesterday, the first class, that the definition of pharmacokinetics is the absorption, distribution, metabolism, and elimination of drugs. So it's those 4 areas. They make up kinetics. Kinetics means movement, so moving the drugs in and out of the body, in, around, and out of the body. Absorption, distribution, metabolism, and excretion. And probably one of the, if not the, most important issues when you talk about moving drugs in and out of somebody's body, and also distributing them, and also metabolizing them, and also peeing them out or eliminating them, however that's done, is the issue of ionization, drug ionization. So we got to touch on that for a little bit. And I made up a little way to figure this out, and we're going to go through that for today and the next class. So put your pens down. Don't write anything. Please just listen to me. Let me talk. All right? Ionization. All right, we're going to do some chemistry. Very little. All right, when they say drugs are chemicals, when I say that a drug is an ion, or is an ionized form, what it means is it has a charge on it, plus or minus. So a drug could exist as non-ionic, it's just the drug itself, or it can exist as ionic. The reason is, when you take a drug into the human body, it's the same as, there's no difference. It's the same as taking that same drug, that powder in the drug company laboratory, and putting it in solution, a beaker of water. The body is a water medium. Inside the body is all water. And lots of other stuff too, but basically there's water everywhere, right? Among other things. A pharmacokinetics person looks inside the body and they see a bunch of different compartments. They see the blood compartment, the brain compartment, they see the GI system. If it's a pregnant woman, it'll be mom versus the fetal circulation. If it's a nursing mom, it'll be breast milk versus the mom's bloodstream. So there's a lot of different compartmentalizing that can go on in the body. And what determines whether a drug, where it distributes to in the body, is determined by its ionization. How it's absorbed, metabolized, and eliminated is also determined by its ionization. Now, since drugs are ingesting them and putting them in the body, it's exactly, or chemically will behave exactly the same as putting a chemical into solution. So you can just use basic chemistry to kind of understand it. All right? And if you take a drug and you put it in solution, it'll have a tendency to interact with water, and the solution is water. That's what I mean. And water has H plus and OH minus, right? H2O. So it can form bonds with the water. We say that it's soluble in water, it dissolves in water. Use whatever term you want. If you take this, 10 grams of this drug powder, I drop it into a beaker of water, and I shake it all up, and if it dissolves, it interacted with the H and the OHs. We also say it was soluble, and we'll talk about the properties from there. If it doesn't interact with water, because of the chemical groups and all that, it just clobs up and then drops to the bottom in big clumps, and it looks ugly, and it is not soluble in water. All right. What determins whether a drug is soluble in the body or a chemical is soluble in solution is whether it will react with the H's and the OH's. All right. Whether it has certain groups that are able to exchange electrons and protons, and remember all that's kind of good stuff, and interact with the water. You can have, for example, you know this, you can have calcium in the body, Ca, or you can have ionized calcium in the body, right, where it has a charge on it. So it depends on where it is and what it's interacting with, and so on and so forth. So, if I take when a drug gets a charge on it, a plus or a minus, we say that it's ionized, charged. That's all it means. All right, so a drug can exist as 100% ionized in the body. It's all got a charge on it. It can exist as 100% not ionized in the body, no charges. Or it can exist as some percent of each, some fraction of 50-50, 75-25, 63-47, whatever, or 37, whatever the case may be. Now, let me I'll go on my camera. Give me a second. I don't need color for this. All right, this is page 14. You don't have to turn to it. I'm just using this to make a point. If you take a drug in the body, it's going to pass cell membranes to get anywhere. All right? So let's say I swallow a pill, and I want it to get into the bloodstream. I want the bioavailability of it, right? It's got to go in the blood, so the blood carries it to wherever it goes. It's going to have to cross the gastric cells, or in the intestine, the intestinal cells. It's going to have to cross some barrier, right? GI barrier. And the barrier is made up of lipids. So let's say, have we got a pen I can borrow? Oh, here's one. Thank you. So here's the lipid bilayer here. And if I have a drug, the drug, in order to get in to the cell, pass through the cell, has got to pass through the lipid bilayer. And if it has a charge on it, plus or minus, if it's ionized, then what happens is it gets to the cell membrane and it sticks to it. It can't go through it. Because this is a phospholipid. Remember, the cell membranes is a bilayer, lipid bilayer, phospholipid, the Singer model of cell membranes. He won the Nobel Prize. Everybody's all excited. If the drug's trying to go through here, and it's got a charge on it, it can't. Because these phospholipids in the top are negatively charged. They put a negative coating on there, and the charges stick to each other, and the drug can't get through. So in order for a drug to pass a biological membrane, it's got to be non-ionized, no charge. This way, this is lipid bilayer, this way it'll go right through and right in the other side. So that's given number one. In order to pass, well, let me see. Given number one is ionized means charged, non-ionized means no charge. In order for a drug to pass a biological membrane, it's got to have a no charge. If it has a charge, it won't pass. All right, so we say this. We say that drugs that are charged or ionized are water soluble only. This is the rule of pharmacology, the basic rule, the cardinal. This is the 10 commandments of pharmacology. Can't be any more dramatic than that. So ionized means charged, means water soluble, means can't pass through biological membranes. Non-ionized means no charge, and that means lipid soluble, can pass anywhere it wants. So that's rule number one. All right, everybody with me so far? I'll give you an example. You gave somebody rocuronium, all right? You all done that, right? You go to ICU, you want to paralyze them, get them laid nice and still. You give them some rocuronium, and you give it IV, and you wait a couple minutes, and boom, they're paralyzed, right? No problem. You take that rocuronium vial and drink it, what happens? Nothing. Why? Because rocuronium is 100% ionized. Because of some chemical quirks, we'll learn about that in future weeks. The rocuronium is always 100% ionized as a drug. So if I swallow it, it can't pass through this gastric wall. It can't pass through the intestinal wall. If I gave it rectally as a suppository or a solution, we couldn't get it to absorb through the rectal wall, anywhere down through the GI system, lips to the end. It's not going through anything, any biological membrane, because it's water soluble, 100% water soluble, 100% ionized. Well, does it work? Sure, as long as you give it IV, then it can go to where it needs to go. Doesn't have to be absorbed. The blood carries it into the muscles, the receptors on the surface of the muscle, and so therefore the blood bathes them. Drug gets there, paralyzes you, boom. Takes 2 minutes, everybody's happy. Patient lays nice and still and you can go chart. So that's ionized or non-ionized, right? Now, if you want to know whether a drug is going to ionize or not, then number one, you've got to know what the drug is. And number two, you have to know the pH of the solution it's in. Because water has H's and OH's, and depending on the pH of the water, you can adjust that. It'll have more H's or less H's, more OH's or less OH's, right? All right, here's another thing that's totally ridiculous, but I'm going to say it anyway, all right? Whether a drug will ionize in solution, I'm going to liken it to this. Baseball. Let's say I take a drug and I put it into solution. If it's going to interact, ionize, solubilize, dissolve, whatever word you want to use, then it's like having a pitcher and a catcher, all right? One wants to give up protons, one wants to catch them. Acids and bases, right? Remember way back to high school chemistry? Everything's either acid or basic. Acids give up protons, bases accept protons. Protons in this case are hydrogen ions. So it's like a pitcher and a catcher. The pitcher throws the ball, the catcher catches the ball. And if you have a right situation, you got a baseball game. If you put a drug in solution that's not going to interact because the chemicals are not favorable, the groups aren't, or the pH isn't favorable to the solution that it's in, then it's like having two pitchers and no catcher. Everybody wants to give up protons, there's nobody to take them. Nothing's going to ionize. Or you got two catchers and no pitcher. Everybody wants to accept the protons, there's nobody to give them, to throw them, pitch them. So you got to have both. You have to have acids and bases together. All right, so let me say this. I'm almost done. Don't write. All drugs are either weak acids or weak bases. Either they're going to want to give up protons or they want to accept protons. They all are. Now, a package insert, everyone you read, all the pharmacology books will say this. Such and such a drug is the salt of a weak acid. They give you the chemical name. Or it's the salt of this this base, and they give you the chemical name. All right. In chemistry, a salt is an acid and a base stuck together. That's the definition of a salt. So a salt is an acid plus a base. It excretes water. If you put water back into a salt, it breaks up into its component acid and base. All right, I'll give you a little cheat. I'm going off on a tangent, all right, if you don't think this is all a tangent. Here's a tangent. Demerol hydrochloride. You looked at the package, right? You all given it. Morphine sulfate. Let's use that one. That's the name of morphine, isn't it? Well, morphine's put in sulfuric acid. That's what the sulfate comes, to make a salt out of it. So is morphine an acid or a base? It's a base, right, because it's in an acid. In order to be a salt, you got to put an acid and a base together. All right? Demerol hydrochloride. Demerol is put in hydrochloric acid to make a salt out of it. Is demerol an acid or a base? It's a base, right? Sodium pentothal. It's one of our old drugs we never use anymore. Right? Pentothal was put in sodium hydroxide. It's a base, basic solution. Was pentothal an acid or a base? It's an acid, right? So, my point is, drugs are salts that makes them stable. You can package them and put them on a shelf somewhere for a couple years. And when you take them back into the body's all water, and immediately they separate in a matter of milliseconds back into whatever the base was or whatever the acid was or whatever. Okay? But all drugs, my point is, I'm trying to get to, is all drugs are either weak acids or weak bases. So then when put in solution, they're going to act like an acid or a base in this solution, water, the body's water. And they're going to ionize or they're not going to ionize. Well, how do you know which it is? Do they ionize or don't they? How much? 100%? 50%? 10%? Whatever. Well, each drug is given what's called an ionization constant. If you look on the top of page 30, there it is. pKa of a drug. Now in chemistry, the P stands for a log system, so that it's a logarithm, the number they're going to give you. Who cares? The K stands for constant. It means it never changes. It is what it is. And the little a stands for acid. So a chemist would say the pKa of this acid is, and they give you the number. That's the logarithm, the number. And then if it was a base, you'd say the pKa of the base is, the pKb of the base, little b, is whatever, they give you a number. In medicine, it's too much trouble. We just call everything pKa. Even if it's a base, we just say pKa. Okay, I know it isn't. Sue me. I got a patient to take care of. I'm not worried about being chemically correct. So we call them all pKa's. So let's read what I wrote here, top of page 30. The pKa of a drug is it's called the ionization constant of a chemical. By definition, the pKa is the pH of the solution where the drug will exist as 50% ionized, 50% not ionized. All drugs are salts of a weak acid or base. So it's the 50% point. That's what we always go to. Seems that we always end up there, don't we? ED50, TD50, pKa. We want to be halfway. So what does it mean? It means this poor guy in the drug company took this compound, he got a big beaker of water, he stuck it in there, and then he started buffering the water, changing the pH, and he did it a little bit, and then he could measure the electricity in the water, and believe me, there's techniques to do this, and he could figure out at what point 50% of the drug he put in there was charged, is ionized, and 50% was not. And he said, okay, that's the pH, it's 50-50, then we'll label that the pKa of the drug. So the pKa is a pH. It's a pH. It's the pH at which this compound exists as 50% ionized, 50% non-ionized. All right, everybody with me so far? Let's take a look at page 32. Just to give you an idea. There's a table on the bottom of page 32. This is from some biochemical pharmacology book. Ionization constants of some common drugs. The pKa's are listed, weak acids, weak bases, and so on. Oh, that's 3 columns long. Oh my God, it's going to give me a headache if I ever had to learn that. All right, we don't. But I just want to show you that they figure all this stuff out. Somebody does. They figure out the pKa. And these pKa's are pHs at which the drug would exist 50-50. 50% ionized, meaning it won't pass anywhere, totally water soluble. 50% non-ionized, it'll go anywhere it wants, no charge. Now, let's talk about some pHs in the bodies. You're right on page 32. Look at the table on the top. This is from Brody's Pharmacology book. It's a famous intro to pharmacology book. pH of selected body fluids. So here he's saying, look at gastric juice, pH 1 to 3. We know the stomach's a nasty environment. That's the whole point of the stomach, right? It's got a lot of enzymes to break stuff down. It's acidic. It churns. Tries to make the food stuff we swallow, breaks it up into component parts and so on. So we know that the gastric juice is pH 1 to 3. Small intestine. If it gets through the stomach, once you go through the stomach, through the sphincter into the intestines, then the first thing you get into is pH 5 to 6. So your intestinal pH is back to closer to normal, 7.4, than the stomach pH. And that's the whole point of the stomach. It's supposed to be a nasty place, right? Ileum, pH 8, large intestine, pH 8, plasma pH, of course, is 7.4, you know that. Cerebrospinal fluid pH is a little bit more acidic than blood. See, that's 7.3. We do spinals, we dump drugs into the CSF. We have to figure out how much ionizes or not. Urine pH is anywhere from 4 to 8, depending on your diet and what you ate and how dehydrated you are, etc., etc. So my point of all this is to show you that in different parts of the body, there's different pHs. Now, if I have a drug, let's say I have a drug, and, well, go back to page 30. I'm almost done. To my scale here. All right, and this is my little method to figure it out. You can determine how ionized the drug is mathematically. There's something called the Henderson-Hasselbalch equation, and you can do a lot of very high-level algebra, calculus, and math, and all the rest of that stuff, and you probably quit anesthesia school. And I would too, because it's too boring. So what I've done is, I always say that after I had a couple of martinis one night, I figured out this little system for figuring out how much ionized or not ionized the drug is in the body to give you kind of an idea of what's going on. And this is my little system. So you look at this scale. I'll go on the camera and point. if you take the pH and the pKa. So you take the pKa of the drug, that's a constant. It's always going to be the same. And the drug company figures it out and puts it in the lingo or information of the drug. Then you look at the pH you put it in, stomach, intestine, blood, CSF, urine, whatever, and subtract the two of them. And if the difference between the two, pH minus pKa, or pKa minus pH, it doesn't matter, is 0, there's no difference, in other words, it's the same, then it's 50-50. 50% ionized, 50% non-ionized. That's the definition of pKa, right? So when they're the same, the pKa is the pH at which they're 50-50. So if you subtract the two, and you just use the absolute value, that means don't worry about the sign, just the numbers. So let's say I have a drug whose pKa is 8.4. I'm making this easy on myself. If a drug with pKa is 8.4, I give it IV. Take a syringe, inject it, here we go. So my first part of my thing is, how much ionized is this drug? Well, you subtract the two numbers from each other. 8.4 minus 7.4 is 1, exactly. So the difference between the two of them is 1. Now these are logarithms, remember. It is really 1. There's a 10 times difference, right? It's 1 to the first and all that. So, if the difference is 1, now look at my scale. If the difference between the two numbers is 0.5, they're going to be 75-25. Right? If the difference is greater than 1 or greater, then it's 99-1. 99, never commit to 100, right? 99 means essentially 100, right? So what I'm saying is, if I take this drug X, whose pKa is 8.4, and I give it IV, blood pH is 7.4, I'm taking 7.4 minus 8.4, the difference is 1, and what I'm telling you is, if the difference is 1 or greater, and it is, it's 1, right? Then it's essentially 100% something, 99-1. It's 100% ionized or it's 100% non-ionized. You don't know yet. There's a part 2 to this. You know the number, it's 100% something. Everybody with me so far?
Yes.
Let's say that I have a drug, well, we'll do some practice ones next week. Let's say I have a drug, and the same drug, and instead of giving an IV, I give it a pill. pKa is 8.4. I swallowed it into the stomach. Gastric pH is 3. So it's a drug with a pKa of 8.4, and it's in gastric pH of 3. What's the difference between the two numbers? 5.3, right? 5.4, I'm sorry. I can do math. So the difference between 8.4 and 3, subtract from each other, is 5.4. Well, if the difference is 1, it's 99-1. This difference is 5. That's 10 to the 5th, right? That's like 10,000 times more something than another thing, ionized and non-ionized, right? It's in one form or the other. It's ionized versus non-ionized. So there's 10,000 times more, 100,000, 10 to the 5th, more of one form than there is of the other form, right? So, part 2 of my little thing is, how do you know which is which? Is it 10,000 times more ionized versus non-ionized? Or is it 10,000 times more non-ionized versus ionized? Right? Here's part B. If it's a base, the drug's a base, and it's in a more basic pH than its pKa, it's not going to ionize. Now just follow me. Don't write anything. Right? I got it all written down for you. Drugs are either acids or bases, so you have to know ahead of time if the drug is an acid or base. So let me go off on a tangent again. I want you to wipe out of your mind this stuff about acidity and blood gases, all right? This is 7.4 is normal pH in the blood, right? For a drug, a pH of 7 might be acidic, or a pH of 7 might be basic, all right? Drugs are not the same as acid base in the body, all right? You have to know whether it's an acid or a base. I have to tell you, this drug is a base. This drug is an acid. You can look in the package insert and they'll say, this is an acid compound. This is a basic compound. And that's determined by what groups are in there, nitrogens and benzene rings and sulfurs and all the rest of that good stuff. That's determined ahead of time by what the drug looks like, made of. So let's say I have a drug that's I told you that one, 8.4 pH, I gave it IV, and I'm telling you that drug is a base. So you got a basic drug, pK 8.4, and I gave it IV, so it's in a pH 7.4. I take the difference between the two numbers, and we said it was 1. We already did this, right? All right, so it's going to be essentially 100% something. Right? You with me so far? Is it going to be 100% ionized, or is it going to be 100% non-ionized? Well, it's a basic compound, I told you that. And it's in a more basic pH than the pKa. If the pH is lower than the pKa of the drug, then the pH is basic. The pKa of the drug is 8.4. The pH of the blood is 7.4. So a pH 7.4 blood is more basic than the pH of 8.4 of the drug, pKa of the drug. Why? Because remember, the pKa is a pH. It's the pH at which is 50-50. So what I'm saying to you is this. I have a basic drug, and its pKa is 8.4. That means when the pH I put it in is 8.4, it's 50-50. I'm putting it in a pH of 7.4 because I'm giving it IV. So now what? When it's in a pH of 8.4, it's 50-50. And I just told you I gave it IV. That means it's in 7.4. So now what it is? 60-40, 30-10, more ionized, more non-ionized. How do I know? Well, if the pH you put it in is lower than the pH of the drug and it's a base, it's in a more basic solution. 2 pitchers and no catchers. 2 catchers and no pitchers. A pitcher and a catcher, right? If I take a drug, a base, and I put it in a more basic solution, it's not going to ionize because both compounds want to accept protons. They don't want to have anyone to give them up. You got 2 catchers and no pitcher. Right? I know a lot of you are lost, but we're going to keep going through this. It's going to make sense, I promise. So, I'm telling you, this drug that's a base, and I put it in IV pH 7.4, then it's going to be in a more basic solution, so it's 100% not ionized in the body, in the blood. So where's it going to go when I give it IV? It go anywhere it wants. It's lipid soluble. Does it pass the blood-brain barrier, get in the brain? Absolutely. In a heartbeat. I give somebody rocuronium, it's 100% ionized in the body, no matter what. I'll just tell you that, without my little tricks. And if I give it IV to somebody to paralyze them, you've all done this many times. What are the CNS effects of the drug? Zilch, none. Doesn't pass the blood-brain barrier. That's a lipid barrier. You got to be lipid soluble to get a drug to go in the brain. You can paralyze somebody and they're wide awake. It has nothing to do with their brain. You got to make sure they're sedated so they're not laying there paralyzed, wide awake, scared to death. You get a stress ulcer and sue you. So in order to get a drug to pass from the bloodstream into the brain, it's got to have some non-ionized fraction. It's got to have some lipid solubility. You can imagine most of our drugs are very lipid soluble, right? Because most of our drugs go to the brain. That's what we're trying to get them to. That's drug distribution. All right, what about absorption? What if I take a basic compound, I swallow it? This pill, 8.4 pH. I'm sorry, pKa. 8.4, same drug. Make a pill out of it, swallow it. Gastric pH 3. Are you going to absorb that drug? Let's figure it out. pKa 8.4, gastric pH 3. The difference is 5 point something. So it's 10 to the fifth. It's 100,000 times more something than another thing. In this case, it's a basic compound in a more acidic pH. So it's going to be ionized. Is it going to be absorbed from the stomach? No. I know how to quiet a room down, don't I? All right, so here's what I wanted you to kind of hit for today. Don't worry about any of this. I don't want you to say, oh my God, I don't know what he's talking about. Oh, you know, the guy doesn't make sense. Well, that may be true. But this is gonna be very simple for you. And I'm just giving you the big picture first. We'll get into the details. See, on the next page, I got all these examples, and we'll go through them, and it'll be fun, and you'll just love pharmacology. You won't forget it the next day. But all I'm trying to say for now, what I wanted to leave you with for this day, is to realize that drugs exist as either an acid or a base. And in chemistry, in the human body, when you drink a drug into the body, it's like putting a chemical in solution. And because they're either acids or bases, they're going to react with the water in your body, it's everywhere, to either have a chemical reaction with that water or not. They're either going to gain a charge or they're not. They're either going to be ionized or non-ionized. They're either going to be lipid soluble or water soluble. And that's going to determine, number one, whether they get absorbed, because if they're water soluble, you can't absorb it in the GI tract. Number two, it's going to determine whether they're distributed to. They got to be lipid soluble to pass the blood-brain barrier. What if I give mom, well, I'll give you another example. I got a pregnant mom, we do a lot of OB anesthesia, I mentioned yesterday. So you get called to do an emergency section. You got to put mom to sleep. We try not to, we do regional for that. But in an emergency, fetal distress or whatever, you're going to have to do general C-sections, we all do. And you got to paralyze mom. So you give her rocuronium for the case. Does the baby come out paralyzed? No, why not? You're right. But it doesn't pass the placental barrier. You're right. Because it's 100% ionized. Because rocuronium, so I don't even have to know whether it's rocuronium or not. All I have to know is it's 100% ionized. It's not going to get to the baby. Does the baby come out with the propofol in him that I gave mom to put her to sleep? Sure. Because it's lipid soluble enough to get in the brain and knock mom out. It's lipid soluble to pass the placental barrier and suppress the baby too. So they may have an initial low APGAR score and you slap them around a little bit and it comes out. That kind of thing. So whether it passes the placental barrier my point is it has to do with absorption of drugs, distribution of drugs, where they're going to go once you get them in there. It has to do with elimination or metabolism of drugs. And I'll just say this quickly. When the liver, most drugs are metabolized, not all, but most, looks at a drug, what the liver tries to do is do some chemical reaction to the drug to make it more water soluble, to make it ionized, to gain a charge somehow. Why? Because then when it gets to the kidneys are a water system, you'll pee it out. So most of drug metabolism are chemical reactions that are trying to make whatever the drug is more water soluble, so that when it gets to the kidneys will pee it out and then it'll be gone. So you'll see it has to do with metabolism and of course elimination, because the kidneys are water system, then water soluble matters. Lipid soluble drugs are reabsorbed in the distal tubule and keeps floating around the body, and they have longer durations, and we'll get into all that. All right. So my final statement. The ionization of a drug is a very important property to determine its kinetics. This is absorption, distribution, metabolism, and elimination. And we can determine what is ionization, what's gonna be absorbed and what isn't, how much is gonna be floating around where, by having some understanding of the pKa's and the ionization constants of the drugs. All right, we're gonna pick this up right where I left off. I promise you next Thursday at 8 o'clock, I'll see you then. Welcome to Anesthesia School.